I'm Dr. Randy Martin. We're here at the 2023 AATS Mitral Conclave, as you can see over our shoulder. And this morning we had an interesting discussion by these two fine colleagues, Gilles Dreyfus and Anelechi Anyanwu. And Ani and Gilles, we're talking about the French Connection. This is 40 years to sort of the anniversary of the famous paper and Professor Carpentier's. What's been the impact of that paper, specifically when it was introduced 40 years ago?
The impact 40 years ago was such a tremendous change in the paradigm of how to treat mitral valve regurgitation that everybody was interested, but it took some time to be adopted because you well know that the rate of mitral valve repair was kept very low until the last 10 years.
Right.
And in the last 10 years, there has been a burst due to some very selected centers of excellence, providing close to 100 repair rate with less than 1% mortality and treating nearly all the mitral valve that are amenable to be treated by a mitral valve repair. But before that, there was sort of a reluctance because you need to really, from a replacement to a repair, you need to take time, you need to be prepared to face a second pump run. So it was not easy.
You gave a talk on that this morning about basically the 40 years in duration. So if I understand what Gilles is saying, even though the paper was presented at the AATS and then published, it didn't lead to a rapid confirmation of that from the circuit.
No, it didn't. It was sort of a paper ahead of its time. So the impact was delayed. So I think what it did was to, bring the awareness that there's this operation that might work for mitral valve regurgitation, but it took, I would say, a good 2 decades. Because even when I was a resident training, I trained with Professor Dreyfus. And I remember sometimes we'll be in one operating room and in the next operating room, another surgeon is replacing a valve for P2 prolapse in the same hospital. And this was in the early 2000s.
Yeah, I'm thinking about, so I was at Stanford in the 70s, okay? And then we went to the University of Virginia in the late 70s, and I didn't hear anything at that period of time. It was all valve replacement. Mechanical at Stanford, obviously, the biologic valves and stuff. What's his legacy? I know that's a difficult question. You both worked with him. You spent some time.
I spent many years.
You talked about it this morning, and I thought it was interesting. You made some really interesting comments. What's his legacy to you and then to the field?
His legacy to me is huge. We have today lots of publications on techniques, results, but I really think nothing that is done today, except a few minor changes, have not been described by Carpentier. And what Annie showed very well in his talk is that basically he picked up 10 principles, but these 10 principles remain intangible. You can do whatever you want. You can use Gore-Tex, you can use caudal transfer, you can avoid resecting or not. But I mean, what you want to have is a perfect closure line parallel to the posterior. Because if you don't have that, you don't have a good coaptation height and restore a coaptation height. And once you've done that, whatever the technique, basically you've done a good repair, which should be lasting for a long time. I really think that what Carpentier described 40 years ago is still true. I mean, it's not because, we've abandoned quadrangular resection because it put the tissues under tension, although the results at 20 years were very good.
No.
But, I mean, yes, triangular resection seems to be more suitable. But aside of that, I don't think there is a major change. Yes, you can use a band instead, incomplete rings instead of complete rings, but I don't think there has been a major change.
I think the other important thing to note is that those principles you're talking about apply to percutaneous therapy too. And if you have a percutaneous technique that doesn't follow those principles, it's bound to fail. It's the same principles of, that Carpentier laid out that will get you a competent valve for a durable period of time, no matter the method used.
And it was built upon his knowledge of anatomy and function. I mean, it's really pretty dramatic. Was he and is he a futurist? In other words, he's obviously, the way you talked about him, he's He was driven. He was insightful. He was
Yes,
totally committed. But was he a futurist? I sort of got that from your talk. I mean, you said he was before his time.
I'm perhaps biased because I've been working with him, and I have some feelings because he was my mentor and intellectually truly admirable person. Now, even what Annie says reinforces this message, but what also we heard this morning is that, he described all the disease without the echo.
Right. No.
And this has been confirmed by the findings of it. I can remember that, Carpentier used to have a stethoscope, which was a sterile stethoscope. So he would put a stethoscope to hear if there was a residual murmur after a repair. But I mean, we had nothing. And then the first echoes, we put the probe on the heart, and then we were trying to find the incidents, which we were searching to see sort of a hazy image to see whether the mitral valve was correct or not. But I mean, all what he described was coming from his mind. And this is truly something which was admirable.
He had complete integrity, too, didn't he, in the way he approached the subject. In other words, he was interested in helping the patient and in the outcomes, not making himself famous.
Oh, yeah, of course. I mean, I think I think that he was able to develop that in Vietnam, where I worked also with him, where he developed this center. But, for instance, I've done the same thing in Africa, and it's a bit difficult that they understand that a repair is better than a mechanical valve. The problem is then, can they afford a second operation when it fails? This is all the point about the durability of mitral valve repair, which we face even in developed countries such as America or Europe.
Your thoughts, you put together, you gave a talk this morning, but you obviously knew him and have known him. Putting the talk together, did you learn new things about him or new insights?
I learned a lot about him. Like this morning when Professor Perrier was saying, he wasn't just doing mitral valve, he did a lot of other things. So in doing my research for this talk, I came across a lot of work from the 1960s, 60s and 70s that he had done. And I sort of got the impression, as Prof said this morning, that he and his chief, Dubos, were not necessarily on the same path, because I read some of Dubos' papers and read some of his papers, and I could read between the lines that there was a big difference of opinion. And when you say legacy, his biggest legacy is actually the bioprosthetic valve, which many people don't know. That's really his biggest contribution to surgery. Was probably was glutaraldehyde he used? Glutaraldehyde fixation of valve. That's really what changed valve replacements worldwide.
Yeah, I know. It's interesting. You knew him when you were younger, obviously. He was much younger.
Unfortunately, yes. Thank you to remind that.
Sorry. Well, everybody's younger than me, but so he was. And then you've obviously known him over the years.
Yeah, I still see him regularly.
Has anything changed about him and your perception? In other words, if you've looked at him, working with him being your mentor, and you were both much younger, you see where in other words, maturation, age causes maturation in some people's personality, but not their inherent who they are. Have you seen any difference in him? Besides, you knew him as a trainee, and he was...
I knew him also as a professor. I knew him as a fully independent surgeon. That what has changed is I think he accepted, he didn't want to always be right. I think he gave his message, and if people didn't believe it was right, because you see today, you hear the development of mitral repair, it seems that there is a sort of a new era.
Right.
I really think it's a bit exaggerated. I think that, whether it's Gore-Tex or whether it's native cores, and as rightly Cody is presenting a paper at the AATS, which he did present a bit of today, saying that, if you use Gore-Tex, there are 690 ways to use Gore-Tex. If there are 690 ways, it means that Gore-Tex has a bit of a problem. At least, I'm not against putting one or two. If you put 10 Gore-Tex, in order to achieve an evenly distributed closure line, it's getting very difficult. It's getting very difficult. So people never talk about that. And I think that Carpentier delivered many talks, tried to be convincing. I know that there are pros and cons of what he said. But I mean, I thought that he was a bit reluctant to try to convince people who didn't want to believe what he says.
That's what comes with aging. You know who you are and you know who they are with aging. I mean, his integrity at doing what he thought was right was not based upon popularity or how many Twitter followers you would have, as people do today.
Not at all. Not at all.
But it was
based.
But it was not instantaneous. I mean, he developed this whole concept with all. He told. I mean, the one time I had a chance to sit with him with David at the AATS in Toronto when he was. He talked about the sheep. Sheep got loose from his operative sheep who were running down the street in Paris and all, and talked about and it would just showed how he really developed his techniques methodologically and really perfected them.
If I may, what seems to be today part of our mandate to treat mitral regurgitation is accepted and no one can discuss that the gold standard is mitral repair. But I mean, in 30 years ago, 40 years ago, 20 years ago, treating a valve that was diseased, I heard so many times people say, how can you get a good result? As the valve is a diseased tissue, how can you restore a proper valve? And even this concept is revolutionary, and it remains such.
Adi, as you both are still training young surgeons today. Are there things you can see in the way he trained people? And I mean one-on-one and then the team concept or the concept of how you plan operations, you do operations. Is that a transferable message for you, in other words?
Well, I never trained directly under Carpentier, except when I was doing my fellowship at Mount Sinai, he used to come and operate. So I did scrub with him on a handful of cases. But I think training really comes from the legacy and what you transfer to your trainees. And although I didn't spend years with him, I feel like I did, because I've spent years with Dreyfus and Adams combined, who learned from him. So in many ways, it still gets transferred down the line. And hopefully other trainees of Dreyfus and trainees of myself and all the other students of Carpentier will continue to move that on over the years.
Gilles said you had the 10 or 11 principles he had, so you teach the same.
We teach the same principles. And I tell everyone, like the French corrector, I say, this is one paper you have to read.
The reason I asked about the futurist, because he had to be a futurist in the sense of not thinking that you should repair the valve and knowing, but forcefully proving that to himself and to the patients. The highlight you had of what the operating room of the future would look like.
Yeah, he wrote that when, as Prof. Dreyfus said, echo was barely just coming out at the time. And he was saying, look, we're going to have three-dimensional reconstructions and talking about robot-assisted surgery, and it's an amazing vision.
But you look at Club Mitral, which was a phenomenal thing. I mean, it was not only from the knowledge you got, but the relationship with your other members of that club and people. And then you look at a meeting like this where you've got almost 1,000 people, and you realize the legacy is really gigantic. To me, it does.
The Club Mitral was really based on live cases, and Carpentier would do something like 10 live cases in 2 days, or 3 days, and it truly, very often the last case he was on his own finishing the case, and everybody had gone for dinner, and he was in the OR until 10 p.m. or 11 p.m. and he was very much patient-driven. What I said this morning is true, is I'd never seen a surgeon who had so much this concept of where there's a will, there's a way. And he had his will at the tip of his needle holder. When he wanted something to happen, he made it happen. I don't think you can make such a breakthrough in cardiac surgery without having this kind of temper.
It's interesting to me because when I left Emory Medical School in '69, I went to Stanford and I got exposed to the Shumway and Fogarty at that point in time. And although I didn't know Professor well, and obviously I had interacted with Shumway some, there's a lot of similarities in what I perceived as a young man then about them and about Carpentier. I mean, basically very forceful, very driven to, we're going to treat the patient when they need to be treated, not when the clock says. And a lot of, I think it was, this concept that then you'd go to a restaurant or you sit down and he's sort of drawing on the napkin.
Yeah.
The same thing. I mean, so what I'm saying is innovative and great surgeons have a lot of similarities, but they are focused on making the field and making the patient better. Isn't that correct?
Absolutely. This is truly, I think, one of the major messages that we can.
Do you think we have that same drive in transcatheter therapies that we had? I know it's a hard question, as we had in the surgical field coming along. I think that's the same principles are going to exist.
I think transcatheter therapy has a bright future. There is also the industry pushing very hard to develop things. I really think that cardiologists should see what happened with surgery before. As Annie said, I think that provided they don't get a result with trace and even less than mild MR, there will be residual MR, there will be recurrent MR, and we'll have a problem. So, I mean, the intention to treat should be stated in all the cardiological studies. Is it a compassionate use for a 90-year-old man where if he has a regurgitation, residual regurg, I mean, it's not a problem. You're not going to do anything. It will improve his symptoms and it will facilitate the drug impact. If you take someone 70 who has the choice of surgery as opposed to percutaneous therapy, then you have to be very careful what you're doing. And if the results are not perfect, then the outcome will not be perfect. And when the guy will be 75 with torrential MR, he's going to be a high-risk surgery for a patient who could be a low risk at the time of initial and index intervention.
Yeah. I mean, I think the goal has to be to relieve the patients of their symptoms and treat the disease. The goal of percutaneous therapy cannot be to be an option against surgery. It's not all or none. It's not a competition. And I think if they see it that way, because a lot of the innovators in surgery we're talking about today, they were doing that because they wanted to help treat the disease. Correct. They were not doing that because they wanted more patients or wanted to compete against something else. And I think the drive in the percutaneous, there's a lot of commercial interest, and as opposed to trying to help, do what doctors do, treat the sick.
I guess that's what the point I was making is that having had an experience to watch, really, to see surgery when I was in medical school in the 60s, and then go to Stanford in the 60s and 70s and see the difference in what I think Professor had. I mean, that it just makes the field so dynamic and so professional. I mean, those are not good choices. And I think that's the danger with transcatheter therapies, is that it's basically focused on one procedure and not the concept of longevity. And longevity is tied to your results. Yeah. All right, listen, I learned from both of you this morning. It was great to listen and hear the comments. From your history was really good, so thank you. Thank you for joining.
Thank you, Wayne.
Thank you. As always. Thank you. And thank you for joining us. It's fascinating. Read that 1983 paper on the French correction. It's fantastic.